Good evening, everybody. So I guess people have found the refreshments. They have perhaps found the fun swag in the back. Thank you for coming out on, and I guess we're getting closer to winter-ish day. So my name's Sal Berman. I am the campus's Chief Information Security Officer. And in addition to all those fun duties, as you can imagine, I'm honored to be a part of the Dissonance Organizing Committee. On behalf of this multidisciplinary group of faculty and students, I want to welcome and thank you for being a part of Dissonance, Conversations at the Confluence of Technology, Policy, Privacy, Security, and Law. The Dissonance event series seeks to engage the university community on timely topics of national and global perspective, and I'm reasonably sure this is one of them. Increase university-wide multidisciplinary discourse. Hello, folks from the med school and the law school. Connect faculty, researchers, and students, and we'll get to the student part of this in a bit, and provoke thought and discourse and have fun along the way. And the fun actually is probably the biggest part of this for me, so I know that the speakers here are all fun folks, and we'll make this as challenging a topic as it is, fun and engaging along the way. So Dissonance is made possible through the collaboration of faculty, staff, and students from across the university, and I mean across the university. So I'm going to rattle off some of the organizations involved. The Center for Ethics, Society, and Computing, College of Engineering, Computer Science and Engineering Division, LS&A, the Ford School of Public Policy, the Med School, MIDAS, the Michigan Institute for Data Science, School of Information, the School of Public Health, the Law School, ITS, and my Office of Information Assurance. A few housekeeping items, the usual, cell phones, please keep them quiet. Session is being recorded, and it's going to be available on the Safe Computing Dissonance webpage, so you can watch it at your leisure later. Visit the Dissonance website if you wish to sign up or even suggest future events. We are always looking for more timely topics from not just what we think up, but from you all. Follow along on Twitter at UMichTech. Use the hashtag UMichTalks to tweet along. So with the high-level stuff out of the way, I'm going to turn it over to Gracie Trinidad, who actually was the person who both instigated and organized tonight's event. Gracie's a PhD student in health infrastructure and learning systems. She's completed an MPH in health behavior and health education at our School of Public Health, and a Master's of Science in Design and Health from the Taubman College of Architecture and Urban Planning. I think outside of maybe the law school, you've run out of Michigan degrees you can get. So Gracie, can you please cue up the event?
So we have a really big panel for this evening. The Dissonance Planning Committee is proud to partner with MyChamp to make this evening's event, Protecting Patient Privacy and Big Data, possible. This discussion is moderated by Dr. Brahmajee Nallamothu, Director of MyChamp, the Michigan Integrated Center for Health Analytics and Medical Prediction. He's professor in the Division of Cardiovascular Diseases and Department of Internal Medicine as well. Please get ready for an exciting panel and prepare your questions for the end of this evening. Dr. Nalma.
So good evening, everyone, and it's a great pleasure to be here. As Gracie had mentioned, I'm involved with a group through the Department of Internal Medicine over at Michigan Medicine called MyChamp, and really the group is about bringing together clinical scientists, clinical researchers with computer scientists, engineers, statisticians across campus to try to think about how do we use data, data in different and kind of novel ways. And so it's been really exciting to work on this. We have a number of collaborators in the Department of Learning Health Sciences, and I think that's kind of where the connection with Gracie came. And as I was thinking about what would be most useful for tonight and kind of for a discussion, I thought, well, I'm going to invite 5 of my good friends to talk through a little bit of the issues that we have been coming across. And they're issues that I'm sure I could go through a long introduction, but they're probably well familiar to many of you in this audience. And to walk through this with a concrete example that I think is broad enough to kind of raise some of the challenges that we are all facing as we think about how to incorporate more and more of the data that we are seeing into kind of clinical care. But so as we start, I'm going to introduce a number of the members of the panel, but we want to know a little bit about you too. So I'm going to ask you guys, we have some really high-tech technology from Michigan Medicine, so pull out your phones, okay? And this is going to be a new audience response system. I want you to raise your hand, all right? So if there is an affirmative, please raise your hand, all right? Okay, so how many people are here from the law school? All right, okay. How many people are here from the medical school? Okay, handful. How many people here are from engineering or computer science? Okay, great. Anybody want to be brave enough to share some of the other schools that they might be from? Information? Oh, go ahead.
I'm from Ross Business School.
Oh, from the business school, okay. From where? School of Information, great. Uh-huh. School of Dentistry, okay, excellent. Nursing. All right, wonderful. So a lot of the health, kind of health schools, as well as some of the schools around kind of data science. So that's great. That gives us some sense. How many are students here? Wow, okay. All right, wonderful. Okay, well, this is an amazing panel, not only because, they're really smart, but they're just super fun too. So I'm just gonna ask them to come up and sit as I call them. So start with Nicholson Price, who is an assistant professor at the University of Michigan Law School. Fighting in the middleweight category and defending world champ. All right. So, but Nicholson is well known in the field. He's published a number of really just great perspectives and kind of analytic pieces in many of the scientific journals, so the real journals, right? So Science, Nature, et cetera. Really just very thoughtful about this idea of how technology is being used and its application, especially with questions about privacy. So the next person I'm going to introduce is going to be Kayte Spector-Bagdady, who is also another lawyer. So Kayte is an assistant professor at the Department of Obstetrics and Gynecology, also at Michigan Medicine. And Kayte is actually very involved with many issues around kind of the secondary data uses and their application also to kind of the clinical sciences. And she's also the chair of the Research Ethics Committee at Michigan Medicine. The next is Sachin Ketterpal. So Sachin is a professor of anesthesia, but only on Wednesdays and weekends. The rest of the time, he is the associate dean at Michigan Medicine for research IT. The next two are Hamid Ghanbari. So Hamid Ghanbari is an assistant professor in the Division of Cardiovascular Diseases at Michigan Medicine. And Hamid's been very interested in mobile health and its application. He is an electrophysiologist, so he looks at kind of heart rhythm issues. And that's a big area in which data applications are starting to come about. And so Hamid's been involved with the mobile health study there. And then finally, I'm going to ask Jesse Golbus to come up. Jesse is a cardiology fellow, and Jesse is very involved in this space of kind of data science and its applications to clinical care, and she is involved in kind of trying to launch a mobile health study, but also has been really instrumental in the Apple Watch study, which Sachin's a PI for as well. It's a real-life kind of example of some of the issues that you're going to hear about and how we kind of move forward. So Jesse's going to start, because we are many of us here are physicians. We're going to start with the clinical case, and the clinical case is going to be grounded in a way that will kind of give us some ability to kind of discuss some of the nuances and issues that raise later. So, Jesse, you want to go ahead and start?
Okay, thanks very much. I'm excited to be here tonight. So I'm going to walk you through a case. Mr. M is a 55-year-old man with a history of diabetes and high cholesterol. He experiences chest pain while shoveling his driveway and presents to his local emergency department where he's told that he's having a heart attack. He's taken emergently to the cardiac catheterization lab where the occluded artery is opened and a stent is placed. He is discharged from the hospital after 48 hours. He then enrolls in and completes cardiac rehabilitation, a medically supervised exercise and lifestyle program for patients recovering from an acute cardiovascular event. On his last day of rehabilitation, he's approached about enrolling in a digital health study using a smartwatch and a mobile application to track his health behaviors. He enrolls with enthusiasm. The Health Information and Privacy Protection Act establishes the rights of individuals with respect to use and disclosure of their health information. HIPAA focuses on regulating custodians of data, so-called covered entities. This includes medical providers, healthcare systems, health insurers, and their business associates. HIPAA focuses on regulating covered entities' use of protected health information for clinical care and for research. Information that is de-identified, however, is not protected under HIPAA, nor is the behavior of covered entities nor is the behavior of non-covered entities with respect to use of that information. Given HIPAA's relatively narrow scope, it is becoming increasingly apparent that a large fraction of health-related data and entities fall outside of its jurisdiction and are unregulated. It has become increasingly evident that health-related data outside of HIPAA can be highly personal and at times identifiable. Here, we give examples of how Mr. M's interactions with websites, businesses, and non-medical health providers may impact his health-related data. Patients frequently share data from mobile devices with non-covered entities, often unaware of the potential downstream uses of that data. In the case of Mr. M, he starts exercising with a fitness trainer and provides her with heart rate data from his smartwatch. He also downloads a mobile nutrition application she recommends. While his smartwatch data within the study application is protected under HIPAA, that same information, when shared with his fitness trainer or with the mobile nutrition application, is not regulated. A number of additional examples can be envisioned in which mobile device data could be used to glean health insights. As one example, mobile phone-based location tracking, termed geofencing, could be used to gain insight into when patients enter fast food restaurants. That information could then be combined with smartwatch data to make health inferences. Large amounts of data also enter the health ecosystem from patients' online activity. In the case of Mr. M, he creates a profile on Patients Like Me. There, he shares lessons from his recent medical journey, including his intensely personal struggle with depression after his heart attack. This information could be leveraged, however, by third parties and sold to data brokers. In the case of other individuals, third parties could gain insight into their diagnoses with depression by recording online searches for light therapy lamps or liked posts for other patients with depression on social media websites such as Facebook. This situation is further amplified by the intersection of mobile device and online data with commercial entities. These include data brokers, advertising agencies, internet search engines, prescription drug monitoring companies, supermarkets, home testing labs, and credit card companies, among others, and all are unregulated. In the case of Mr. M, he reads about an over-the-counter vitamin endorsed by other patients on Patients Like Me. He then purchases it at his local supermarket after downloading an online website, online coupon. Those purchases, however, could be recorded by the supermarket and by his credit card company. They could then be sold to third parties, such as data aggregators, under companies like Google, Amazon, and Facebook. The confluence of growing health-related data, increased computing power, new technology, and new stakeholders creates both opportunities and challenges. In the case of Mr. M, his interactions with the medical profession and then his enrollment in a digital health study clearly empowered him to take ownership over his health. As a byproduct, however, he generated unregulated digital data which may be used with potentially unforeseen downstream uses. This online and mobile device data provides a wealth of information which may be then leveraged by third parties and used in ways that patients do not foresee.
Thanks, Jesse. All right, so this is where it kind of gets really fun. So I'm a cardiologist. I'm an interventional cardiologist. I put stents in for a living, although this past weekend maybe it'll be less. So I just want to say that there's a lot of realistic kind of thought that we put into this. This is a very common scenario and case that we see, and it's increasingly something that we're coming across as we think about, bringing patients on board for studies that we're interested in. And we've also struggled with this in terms of our own kind of insights and questions about what is our role as providers or even researchers in terms of educating patients across the spectrum of what they can expect to see. So I'm going to start with just asking Nicholson, who is really a thought leader in a lot of these ways. When you hear this case, Nicholson, yeah, you, Nicholson, yeah, thought leader. What kind of strikes you about this case and some of the issues that are really important as we start to see mobile health taking off?
Yeah, so I want to take this opportunity to kind of rag on HIPAA for a bit, because that's always a fun thing for a health law professor to do. So I want to start by saying two things that I think are bad about HIPAA, and then I want to continue by saying two things that are bad about HIPAA in a totally different way, and then kind of wrap it up by talking about how HIPAA really just doesn't work at all for what we're thinking about doing. So I want to start out with something following up on the basic points that are made here and kind of lump them into two different ways that I think HIPAA is under-inclusive, which is HIPAA is based on the idea that the data that are important about our health are the data that are collected by the health system. And that the people that know things about us in a health sense are the doctors and the hospitals and the pharmacies and whoever, and the insurers, like the people that we're interacting with as we go through our life in a hospital or a doctor's office. But just as we've realized that keeping people healthy means more than just treating people when they're sick, it means interacting with people when they're healthy and trying to help them stay healthy and not come into the hospital in the first place. It's the same thing with data. We've realized that data all across the spectrum are health data. What you eat, what you buy, where you exercise, where you go, your step counters, all of these things, they're all health data. And this conception that the only people who are relevant to health data are people wearing white coats is wildly outdated and wildly problematic. And just governing those people's behavior doesn't match the way health data really are. The second way that I think HIPAA is under-inclusive is this idea that de-identified data means something, right? De-identification is something that HIPAA says you remove 18 pieces of information and it's not identifiable anymore and we don't really care about it. And that's so far from true in today's world. There are oceans of data and there are people that collect lots of data about lots of things. And if you know a bunch of stuff over here and you've got some de-identified data over here, you can combine them with relative ease, especially if you are a large corporation with access to tons of interesting types of data. So de-identification, not a safe harbor the way we thought before. So HIPAA just doesn't do as much to protect the types of data or the kind of data that we otherwise might think it might. On the other hand, HIPAA is also totally over-inclusive. And I'll start by saying just something that's frankly not about big data, but massively irritating about HIPAA, which is I'm sure something everybody here has encountered when you are trying to do something in the health system that is entirely reasonable, like say, hey, where's my mother? Or, hey, can I talk to this person? Or, what's wrong with my friend? Or, can I pick up a prescription for whomever that I know? HIPAA is really frequently a response that says no. And so HIPAA ends up governing lots of behavior that we actually want to allow in the health system. The last way HIPAA is over-inclusive is the people that we would most like to let do things with health data, which is to say people that don't have a profit motive, that are just trying to figure out, hey, what's up with health? There's not a research exception for those folks either. So HIPAA prevents the kind of research that we'd like to happen, or at least makes it harder. And it doesn't do much to prevent the kind of work that we think is maybe not so great. And so putting it all together, I think the problem with the system we have is it doesn't fit the world we have today. it might have been an acceptable concept of what we imagined health data to look like back in 1990, but it's nothing like what we imagine 2020 is. It stops research we think might be good and doesn't help to prevent the things that we might worry about. So I'll have lots more to say, but for now I just want to say, boo HIPAA, and we should think about how to do this better.
No, that's wonderful. So, yeah, wonderful. So, I do have a couple of questions to come back with you about, but before that, Hamid, you've tried to apply a lot of this stuff in kind of real world settings, right? I mean, maybe you could talk a little bit about your study, about how collecting, the data can be challenging, in particular, hitting some of the points that Nicholson had mentioned about how you have to think about, as a researcher, some of the barriers there are to kind of expanding.
It's always hard to follow Nicholson here, but I'll try. Thank you, Jesse, for presenting that case. I'm a clinical electrophysiologist, and I specifically deal with an arrhythmia called atrial fibrillation, which is an irregular heart rhythm. The problem that we see often is that I see patients in clinic and they come to me with a problem. They have a short conversation with me over maybe 5-10 minutes, and then after that 5-10 minute conversation, we decide whether we should do surgery or we should give medications, and we felt that this is a wholly inadequate way of dealing with disease. So our theory was that this being inadequate, with the help of mobile technology, sensors, we can better understand the diseases and understand the phenotypes and design better treatments. So the study that we're conducting is called the MyAFib study. It's a registry of patients that have atrial fibrillation. We have designed a mobile application that collects symptoms, but also affect, their mood, as well as pulls GPS location, as well as they wear sensors which collects data ranging from their ECG, accelerometer, and bioimpedance data. We do that over a 21-day period of time. So we get massive amounts of data, very dense data, which includes patient-reported outcomes as well as sensor data. And we're seeing all sorts of interesting things, like when it's not the rhythm or the biologic or the physiological parameters that are determining patients' symptoms, but it's their mood, it's maybe the weather, maybe how they slept the night before. So really interesting stuff, and what we are finding is that as far as research, it's really interesting, but for our patients, they find it really enlightening when they find maybe, I thought the disease, the physiological process was driving my symptoms, but now I understand that maybe, I need to move to Florida because I feel worse when it's winter, or I should sleep better, or I should move more. A lot of times when my heart is out of rhythm is because there was a stressor right ahead of time that I could identify and mitigate. So they generally really love the idea, but the problems that we've had is that is hard because it's within a research study. It's hard to use it clinically, the data, so we have to be careful about communicating that data, so that's a little frustrating. Because a lot of the data is actionable already, but we're limited by that. And then patients are generally very happy to participate, and we ask them 21 questions 4 times a day, and they wear tons of sensors, but they're more than willing to participate. We have a wait list that we can't accommodate typically. And mostly it's because they want to understand their disease better. They want to really participate in the care in a whole new way with us. Not the 5-minute conversation that I have with them, but within a long period of time, you could get a real understanding of how disease impacts their life. So that's the major frustration. Obviously, when I started the study, IRB was just kind of trying to figure out what we were doing. So we got lucky with a few things, but I think that we have to be careful about the identification. So the data has to be housed within the HIPAA compliance servers at University of Michigan. So that creates a whole new set of problems from our vendors to work with us and try to house the data within our servers. The data we go through very intense process of encryption on the phone, so make sure that the data that's housed on the phone is encrypted and it gets deleted automatically. We separate the sensor data from the patient-reported data, so mitigate some of that risk as well. But there's always technology risk, and as I've learned, there's things that you can't anticipate. So we're learning as we're doing it.
Yeah, that's wonderful, and I think it's grounded in the fact that you are trying to do this. And Hamid's working with a company, a sensor company, so there's this really interesting mixing of data between kind of data within the health system and in the research community with a private company that has this sensor. And in that regard, as data becomes more complicated, and Jesse had kind of alluded to the fact that multiple organizations can sometimes become involved, each with their own sets of priorities. I'm wondering, Kayte, if you could comment a little bit about that, and just maybe even like last week's headline about one certain large company that was partnering with another large health system provider, just to keep us not from getting into too much trouble.
Well, I get in trouble all the time. It's okay, I'm a lawyer. Sure. So to pivot off of what Jesse and Nicholson were saying, I think it's really important to recognize that back when the HIPAA privacy rule was written in the 90s, the idea was that health information and specimens were governed by method of collection. So either your hospital collected your health data, or it was collected through research, with the human subjects research regulations, and data and specimens largely stayed where they were collected. Of course, now we're in a world where data and specimens go across all of these industries, and it becomes really a revolving door. So governing by method of who originally brought in the data no longer makes sense. And so the regulations I'm going to rag on are the human subjects research regulations. So HIPAA governs our clinical data and specimens, and the human subjects research regulations govern data and specimens that come in via research with people who are federally funded, so generally academic researchers. And there are all of these protections for people who are in human subjects research that is federally funded. So for example, it has to be de-identified, or we have to get informed consent. Again, under HIPAA, if we want to transfer clinical data and specimens to research, it generally has to be de-identified, or we have to get informed consent. But on the other hand, there's this whole other world of commercial health data sharing that they operate under contracts-ish, right? They're operating under terms and conditions that no one reads, that they're allowed to change every time you relog into the system. Did you know that? That every time you relog into the system, you're agreeing to whatever the terms and conditions say that day. And so these data conglomerates, like 23andMe, like Google, are collecting these massive amounts of health and health proxy data, that it's becoming increasingly attractive and tenable for academic researchers just to purchase or use. These data sets are bigger, better, faster, cleaner. But the people who are consenting to them, we know for a fact from Kristen Osler's research at Rice, they don't read the terms and conditions, and they're much more likely to consent if they get some sort of nominal benefit in return, like it counts your steps, it counts your calories. Fertility trackers, women are using fertility trackers in increasing numbers. And we know for a fact that some of these fertility trackers, the data is going right out the door to Facebook to target advertising to you. And this is immensely personal information. So academic medical centers are both commercializing their own data and specimens in order to bring money in to help us fund research. But in addition, we are increasingly using privately collected data for our own research because it's faster and it's easier. And so I understand why the market is acting like that, but we should have concerns the more that academia becomes reliant on private data, because then private data is going to start acting like the private drug market, which we probably all know a little bit about, with price increases and things going off the market. And to get to your point specifically about Google and Ascension, so they recently just announced a partnership, right, it was Ascension, yeah.
Mm-hmm.
They just recently announced a partnership where Ascension Health is going to share up to 10 million identified clinical records with Google. Well, how do you do that, you might ask? Well, because Google entered into a business association agreement with Ascension. And under HIPAA, covered entities are allowed to share identified data with third parties who they're in a business association agreement with if it is to improve your health care or for quality improvement or quality assurance purposes. Generally, those are sort of data trackers, they flag adverse events, they do other sort of small things. No one is thinking of Google as your business associate. And Google has stated that part of that agreement is they're not going to mix those 10 million medical records with data that Google otherwise collects about you. But they have both. So I'll stop there.
Kate, can I ask you a question about that? Did Google say that, but are they legally required? Could they have arranged the BAA in a way where they could have said, you know what, we are going to mix with other things with the idea, again, of improving our services to Ascension Health?
Yeah, so Google would have been prevented from attempting to re-identify data in that way, but given that it's already identified and the agreement was about identified data, so they're already in the business associate agreement, I can't think of any reason that they couldn't just mix it. I think that the reason that they did that was for political purposes.
Sure.
They knew that people were going to be upset, and that is one thing they could say to assuage people, but I can't imagine that in the future that wouldn't be a next step.
Okay. No, that's great. And, I'd love to have at this point, just the last speaker here, last discussant, Sachin. So Sachin Ketterpal is, as I had mentioned, he's one of the associate deans for research IT over at Michigan Medicine. And Sachin also has a background actually in industry too for a bit. So Sachin, when you hear all this stuff, it just sounds so bad. So show us some hope.
Yeah, I think what I've observed is entities will behave as their incentives cause them to. So we shouldn't be surprised when we as individuals do what is good for us, and companies do what is good for them, and researchers do what is good for them. And it seems like in the US at least, the legal construct follows our ethics and our cultures and our values as opposed to leads us there. And so we shouldn't expect HIPAA to be modern even the day that it was enacted into law. Rarely are we seeing regulations kind of take us to the right place. I feel like they're usually putting us where we can convince 51 senators to be, which is probably a couple years ago. But when I was in industry, I was a rational actor. I think that's a term you guys use, right? And if you have a rational actor that has quarterly earnings statements and your stock price goes up literally based upon whether you're hit $2.92 versus $2.91, and your bonus is attached to that, you make bad decisions. So when we think of public companies doing short-term things, that's because that's what we are incentivizing them to do, which is why I stayed in a smaller company that was, had the opportunity to take a long-term view. Not because we were more ethical or smarter or better. Our incentive structure was a long-term incentive structure. And I think that's how you should be interacting with your own data. That's how you interact. I give my privacy to Google, right? On a daily basis, I choose to use Google Photos because when my kids have a project that says, Dad, I need a picture of us at a birthday, I can literally pick my son's picture and all of his birthday pictures from the last 11 years show up. I have given up my privacy for value. And that's what we choose to do, and I think that's what we need to think about. Each of us will make a different choice there. I think the challenge is that we sometimes are, by accident, giving up our privacy in these terms and conditions without realizing where it might wind up, what it could be connected with, and without necessarily having full agency over that choice, I think is part of it. I think there's an assumption here that if I just read all 18 pages, I would make the right choice. Well, when, Kayte's taught me this, when I show up at the hospital, I'm in pain, I'm about to have a surgery, I'm not thinking about the long-term impact of my privacy. I just want the pain to stop right now. And when I choose to download a particular app because I need to for my convenience, I'm not necessarily thinking about the long-term implication of that. So people People and entities behave based on the incentives they are given. As those incentives change, those behaviors will change. So if we are going to make progress, I think we have to change incentives, not necessarily laws. Is that heresy in front of two lawyers?
No.
Okay.
Yes.
Yeah, go ahead.
I couldn't agree more with you. I think the incentives are key, and I wanted to give a plug to our Michigan and Blockchain group and the Center for Digital Infrastructure. I think, that we have to think of this in a whole new way, in a way that, patients are giving their data, but we're building algorithms, so companies are building algorithms that are creating massive profit, and we have to think of new ways of capturing some of the value and transferring it back to the people that are producing it. And I think there's real great opportunity to do that now. So I think incentives are key.
So Sachin, can I push both of you guys on one part of this, though? Like, I can understand Google and what they want from the data. Tell me a little bit about what you think Ascension Health is getting out of this, and then also their ability to share the data of their patients if their patients hadn't specifically agreed to that decision. I mean, do you have thoughts about that?
I have specific thoughts because I actually was part of, I knew,
Ascension.
Ascension, I know a lot of people within that organization, so I
Yeah.
have to be careful what I say. I tend to agree with Kayte a lot. I think there is what people say and then what people do, and I think the incentives are aligned in a way that the data will be marketed in ways that people can't imagine just yet. I think most people don't really know or are not aware of how the data can be monetized. But what Ascension, I think, is planning to get out of it is a whole new way of reorganizing their whole organization in a data-driven organization, and in a way, a partnership that will go on for very long periods of time, where they would continue to go back and forth and create new products from the data that they're getting. So I think this is going to be just the beginning of what we're seeing. So
Go ahead.
Can I just chime in? I think maybe I'm the only one here. I think the Google Ascension deal is pretty great. Honestly, we are so bad at healthcare. No offense, doctors, but we're so bad at healthcare. There's so much that we don't understand because it's wildly complicated, and our tools to figure it out are wildly simplistic. And part of the idea of huge amounts of data and machine learning and artificial intelligence is let's measure a bunch of stuff and see what we can figure out and improve things, so maybe we're not quite so bad at it. And if Google says, hey, Ascension Health, you've got the data of 10 million patients, I'm gonna come help out with you or help you out and try to figure out how to improve healthcare for those patients based on a ton of data in ways that we otherwise can't do. That seems great to me. Now, sure, we should make sure Google doesn't also use that to sell data and sell political ads and blah, blah, lots of bad things, sure. But given, if we assume that they're not lying, they might be, but if we assume that they're not lying and they're actually just doing a one-on-one with Ascension and these data are gonna be kept separate and all they're gonna do is help Ascension do health better, that's great. We should do health better. This is an awesome thing.
And I think it's about those incentives again. Who here thinks healthcare is great and doesn't need to improve radically? Right? There's not many people raising their hand to that, including the doctors that are delivering it on a daily basis. But I think it's about convincing the participant that you're actually going to do that, right? That's the incentive for them, is your healthcare is as good as we can deliver it right now. We need different perspectives. We need different entities interacting with your data and looking at it in different ways. We don't need, adding a year to med school is not the way we're going to make healthcare safer. It's going to be getting engineers and social scientists and nursing teams and business folks. I have an MBA looking at it a different way, but that's a lot to take in the middle of a clinical interaction. When we've got a large study called the Michigan Genomics Initiative, where we've now had 80,000 people have that conversation with one of our recruiters and say, yes, I agree with that premise. So over the last 5 years, 80,000 people have said, I will give up I will share my data with the health system and anybody else they and the ethics board think will advance health and wellness. I have a non-zero privacy risk for doing so. And we do an assessment of understanding when we ask them, do you understand that you will not benefit from this personally, but that healthcare in general might? And they say yes or no. And then we ask them, do you understand that companies may have access to your data and that you may not benefit from it? That is a pretty laborious process, though. We've seen 2 million patients during that time period. We've enrolled 80,000, which is a large group. But think about what we could do with the other 1.92 million. I need a data scientist here. Think of what we could do if those other 1.92 meaningfully said yes to that, not in an opt-out mechanism, which is our easy way of saying we'll do it. It's about getting people to realize you have the opportunity to improve your health or health in general by sharing your data. You have an incentive.
So I'll take your counter argument, Nicholson. So I agree with you that the health system has to improve, and I agree that a great way to do that is more data and more analysis. And I will even stipulate that I'm sort of agnostic on getting individual informed consent for this stuff. Okay, but that said, my concern is not the data aggregation and analysis. My concern is the privatization of that data and the aggregation of that data in private entities, right? So let me tell you the story of Myriad Pharmaceuticals, if you guys haven't heard this one, right? So the BRCA gene has several variants that are associated with the increased risk of breast and ovarian cancer in Ashkenazi Jewish women. And Myriad Pharmaceuticals patented those variants in the early 1990s, and so was the only company that could offer that almost diagnostic test for breast and ovarian cancer. So they held that patent for several decades before the ACLU sued them and said, no, you can't patent something that is naturally occurring in nature. The Supreme Court eventually agreed and overturned that patent, found it to be invalid in 2013. However, on the next day, all of these new BRCA tests flooded the market, but what didn't anybody else have?
Data.
The data of 20 years of BRCA testing, right? And so no one else could do the comparison and analysis necessary to give accurate and reliable BRCA testing like Myriad did. And the way that the other companies have competed with Myriad is they all pooled their data sets. And so that's the only way that they could compete with Myriad. So my concern is not that we shouldn't have better data analysis. I agree that we should, but it really concerns me if Google is going to own the most important healthcare tool that anybody has access to. And also, might I add, that the kinds of people that are more likely to privatize their data to begin with, the kinds of people with Fitbits, with iPhones, with who are doing 23andMe, who are doing Ancestry, are wealthy white people, right? By and large, 80 to 90% of these databases are populated with wealthy white data. And if that's the data we're using because we have access to it, those are the communities whose outcomes of our research are going to be most relevant to.
So I'm going to, because I do want to get to some questions from the audience and stuff, but I do want to ask one thing, just hitting that, because I think you guys have done a great job of talking a little bit about the opportunities of data, but then also the risks, the privatization, commercialization in some ways. How have other places handled this? And maybe I'll ask you, Nicholson, like about, the EU, for example, has a different model for how they deal with this. Maybe Kate should answer this? I don't know, either one.
Play my organ, GDPR. Dun, dun, dun.
The GDPR is the General Data Protection Rule, otherwise known as the goddamn privacy rule, by privacy scholars who, anyway, so Europe has this new regulation. When I said rule, I meant regulation the first time. And it does an interestingly different thing, right? We have a rule that says, hey, health data, they're special, and they're special when they're collected by health data people, like doctors. The GDPR says, hey, data are special, like all your data. We're going to protect all the data as themselves. Who cares who collects them? Just we're going to collect data, and we'll have a couple of extra protections for super sensitive stuff. Maybe some health stuff falls into that category. Honestly, I think the jury's kind of still out on how well the GDPR is actually working. If you remember that period in time, like 15 months or so ago, when you got a ton of emails from everybody that you'd signed up for saying, hey, can you agree to our new privacy policy? That's been the most concrete effect of the GDPR so far. And you all said yes, right? Of course you said yes. Like, Well, who's not going to say yes to like all of them? And so that's been the most concrete outcome that we've seen. So maybe it'll actually make a big difference, or maybe not. I think the jury's a little bit still out. It's a different approach, and it doesn't have the same sort of artificial barrier that ours does, which speaks highly of it, but there are other questions about whether or not it creates big barriers to access for, say, smaller companies, things like that.
Any other thoughts, Kate, or on the GDPR? Or?
No, I think that.
Yeah? Yeah.
What's the alternative to privatization, Kate? Given the cost that it takes to collect it. So, I mean, NIH is trying to, like, what is the viable, not idealistic alternative?
So I think that industry and academia are going to have to work together in order to improve health. There's no way around it. However, I would aspire that we could set better standards that would incentivize the private market to behave the way we want it, right? Because the private market, in order to be a market, needs public researchers who can publish in fancy journals, right? And if you can't publish the data in JAMA, do the data even exist? And so one example of this is 23andMe, when they first started with their first article that they tried to publish with private data and academic researchers, they submitted to PLOS Genetics, and PLOS Genetics said, no, you can't submit to us without IRB review. And 23andMe said, joke's on you, we don't need IRB review because we're private. And PLOS Genetics said, no, joke's on you because we don't have to publish your paper and we get to set higher standards, right? And so actually, that's why 23andMe does IRB review now. And so there are ways that academic medical centers say, you can't collaborate with our researchers unless you do X, Y, Z. There are ways that journals can say we won't publish your research unless you do X, Y, Z. And then there are also community standards that researchers could set and say, fancy researchers say, I'm Sachin, I am not going to collaborate with you unless I know the kind of informed consent everybody provided. So I think that there are other options, but not engaging with industry is not one of them, but there are ways to set standards.
Do you think that's something that's going to last forever? Like we're seeing the papers that are coming out of Google Health, for example. I mean, what's to stop them from publishing on GitHub and putting their data on and bypassing this whole thing?
BioArchive,
Yeah. Like why do they have to play with us?
Because I don't think that Sachin and Brahmajee are going to change their practices based on some data that was published in GitHub, right? Like there's still some authenticity that peer review and publication in good journals lends to actually influence practice. It's still a business asset, I would argue, to be able to use that data in support of renowned peer review publications.
I know that for some reason, like new laws is a dirty word, but we also, we don't have to rely on soft power. We could rely on hard power and say, hey, big company, congratulations, here's a new obligation you have. That's a thing we can also do. And if we want to, we don't need to, but we could say, hey, if you want FDA approval, here are some things you have to do. Here's some stuff you have to disclose. Here are some practices you have to follow. We do some of that already. Or we could say, hey, if you'd like to be reimbursed by Medicare, here are some things you have to do. It turns out we have some big hammers. We as journals and a scholarly community have one set of hammers. We as a polity and members of a body that theoretically at least has the possibility of passing law through Congress.
Oh, that wasn't a joke. Sorry.
Have other powers.
So I'm gonna just ask pause at this moment, just ask the audience because we're down to less than 10 minutes and stuff. Are there folks here who might have questions? Oh.
Thank you. It was a very nice discussion. 2 questions. The first question is, you started with HIPAA. So is one answer to make HIPAA better for today's situation and today's business associates, new versions of business associates? And the second question for the lawyers, will we ever get something like GDPR here, please? Thank you.
Yes. We should make HIPAA better. We could also gut HIPAA and replace it entirely with something else, and we could call it HIPAA or we could call it something else, and I don't really care. But yes, there are many ways we could improve HIPAA. Will we get something like the GDPR? You know, if you asked me back in December, I would have said, yeah, I think so. There seems to be momentum in Congress for actually passing a federal data privacy law. Like California did its thing. Like companies seem to be really irritated about the idea of having a bunch of strong different state laws being passed. And Congress looked like it was going to do a thing, but then Congress did the thing that it often does and didn't do a thing. And so now it's an election season, and I was optimistic once, but fool me once. We'll see.
Yeah, I will also say that I am fairly disillusioned with our both law and regulatory system. So I worked for 5 years in health policy for the Obama administration, and then also watched and Obama submitted the revisions to some final rules over the human subjects research regulations the day before he went out of office, which admittedly was not necessarily the best timing. But so we spent 6 years updating the human subjects research regulations and accomplished almost nothing. And all of the really big things that we wanted to accomplish, like things with pregnant women in research and getting more consent for biospecimens, and like all of the hot ticket items that were on the table were too controversial and didn't make it into the final regulation. So I am very anti-waiting around for new laws and regulations, and think that we as an academic medical community should be thinking about other kinds of solutions.
Is the concern with like passing regulation, is it that the companies are they interested in working with us to kind of revise HIPAA, or because as you had mentioned, Nicholson, I mean the alternative is every state's going to start doing this on its own, and that's going to be a big problem too. I'm just kind of curious, who's stopping this from happening?
Sorry.
Maybe it's not easy to answer.
I'll blame it on stakeholder and congressional inertia, but I honestly don't know. HIPAA is one of a set of laws that just puzzles the heck out of me as to why it stays the way it is. I just don't get it.
Got it.
It seems terrible. It seems like everybody should recognize it's terrible, but every time somebody tries to change it, they're like, change. It's the worst.
Yeah.
What are your perspectives on the 21st Century Cures Act, which passed and kind of piled on top of HIPAA in terms of one part of HIPAA that's often forgotten is not just you can't share data, but as a health system, you must share data if a patient asks for it. And for about 10 years, hospitals, we kind of chose to ignore that part because it allowed us to increase switching costs from one healthcare system to another, so our incentives were aligned to not give you your data so you came back to us again for the next episode. 21st Century Cures Act actually put some pretty good information blocking rules, penalties. The current administration is actually doing a good thing in enforcing some of those penalties, so you can now, much easier in November of 2019 than in November of 2018, demand your health record from the University of Michigan or any other healthcare provider which receives Medicare funding and get it on an app or on a website without going to a room, without somebody telling you, no, you don't understand the security issues here. They're so complex. I can't give you your data to protect you. All that crap is now gone.
You have to fax us.
You have to fax us. All that crap we used to do. Here's the CD with your record.
Right.
All of that crap is now gone. And that, I think, was legislated in. It's the only hopeful thing I've seen. It increases the risk of privacy loss, because now I can take my data and give it to 23andMe, literally on their website I can now do this, and they are now not a covered entity. But is that an example that was lauded or seen, or is it just a dumb luck of regulatory progress?
I think you're right. I am overly pessimistic. Congress does sometimes do things. The 21st Century Cures Act had some cool stuff in it, and that is one of them. I will point out as a side thing that it's funny to me to say it increases the privacy risk by giving you your own data. But yeah.
But you control that risk now, which is great.
Yeah.
Yes, that is a positive thing.
Yeah. And I will also say that going back to a point that you made a long time ago, Nicholson, is I almost think we're out of the business of health data versus data, right? Like all data are health data or health proxy data or health indicated data at this point. And one thing that people don't realize is sort of the mosaicing that's happening between data sets, right? So everybody thinks of their data still in silos, right? So you put into Bumble like the kind of person you're interested in dating, right? And you put onto Twitter the talks that you're giving, and you put into GPS where your kids' daycares are, and you're not thinking of those data in the aggregate. But there are many companies that their business model is aggregating those data under you and selling access potentially to people like us.
I think there's one other question on that scary note. No? No? Oh, come on. Any other questions at all?
Wanted to make one point is that the GDPR does allow you to forget me, which I think is a very valuable thing and is probably the primary benefit that I've seen.
Thank you.
Yeah.
Yeah.
I'm going to wade into it here. Isn't the core issue the conflict between our seeking ethics and integrity versus our concerns about bad actors and nefarious intent? Because you go for a DNA, a 23andMe, and the whole idea is to be connected to my family, get an idea of the history, and where did I come from, and where are my people from, and who am I connected to ethnically and in that diverse big pool. But now that becomes part of what could be used in a nefarious way. I have the gene pool that identifies me as a very expensive potential insurance company cost. So what are they going to do with me? We become a society now globally segregated by our ability to cost or not cost. To me, the implications in this entire discussion are gag-worthy, sorry. It takes me pretty much over the edge to...
Tell us how you feel.
At that concern, there's something deeply, fundamentally private about lots of this information, and it feels problematic. I don't have a great answer, honestly. I think part of the answer that comes to my mind is going along with what Sachin said, which is, there are nefarious actors. There are genuine bad actors. There are also a lot more actors who aren't bad. They're just doing stuff because of the incentives that are set up for them. And so the right way to fix it isn't to think of them as bad, it's to think about how we change the incentives. So when you say, and this is a terrific point, there's a question about DNA being used for discrimination in health insurance, which is a horrifying outcome. And an answer to that is to pass the Affordable Care Act and say, you can no longer discriminate in the amount that you charge somebody for health insurance or whether or not you issue someone health insurance. We can try to deal with the incentives and some of the downstream effects in a way to make some of the things that we think of as horrible privacy side effects less problematic because we eliminate some of the downstream effects. Now, obviously that doesn't satisfy you if the answer is, well, I did a genetic test and now they're talking about repealing the Affordable Care Act. But we can try to make some of these things better. We can't resolve all the issues. I completely agree with you. There's going to be tension between privacy and progress, privacy and innovation. There's going to be some tension there, and that's hard to avoid. But we can try to make some of it better, and that's, I think, the enterprise that we're hopefully stepping forward on.
So it's a couple of minutes after 7, so I think I'll just leave with that, and another round of applause for the great panel. So I want to thank again Saul and Gracie and the Dissonance panel for allowing us to come here and kind of share the evening.
So one more round of applause for this awesome panel. That was a lot in 1 hour, and while not all of it was fun, it certainly was stimulating. So if we didn't nail conversations at the confluence of technology, policy, privacy, security, and law, I don't know what other subject we could. We live in this interconnected world that is about health data and all data. And part of the reason we have Dissonance, part of the reason we are putting these events on is while we in academia can offer some of the solutions, opine on things, I think you heard loud and clear, we need you. This is to activate you to think about what laws you might want or not want, what expectations you might have of companies you work with, hospitals you go to, doctors you go to. So just know that is the purpose of the forum. As someone with a JD, I found it very interesting how much lawyers hate laws. So keep that in mind as we form new laws. I mean, HIPAA, when it was created, did not envision the world of today. It was about healthcare portability. It wasn't about privacy and security. That was a sort of tag on, and yet that's become one of the most important parts of HIPAA. And shameless plug. So there will be more Dissonance events next semester. Dissonance is a co-sponsor of events like Privacy at Michigan in celebration of Data Privacy Day. So I hope you will consider joining us at the Rackham Amphitheater on the 28th. Check the keynote, please, because I'm assuming the crowd will get big. We actually have the deputy editorial page editor of the person who is doing the privacy project. So join us then. If you want to see or hear more out of Dissonance, any particular subjects, please contact us. Information and this presentation will be on safe computing. Last round of applause for this awesome panel, and thank you.